So I'm here with Dr. Louise Oliver, and yeah, this is going to be very interesting. I always think it's brilliant when we have a GP and to talk all about breathing. And I have to confess a little bit in that when I started off 2002, not so many GPs felt that breathing was part of their forte. So, Dr. Oliver, it's great to have you on board. I'm going to call you Louise now from here on in. And we're going to have a conversation about a topic that probably I avoided and most men avoided and probably many women avoid as well. It's all about menopause. We're going to bring in pain. We're going to bring in sleep disorders. And I'm especially interested in, from your perspective, of introducing breathing to the patients that you're working with. So welcome. Whereabouts are you based?
Huddersfield in
Huddersfield. Great. And it looks as if you have just returned from holidays with a nice tan as well. So that's always good. So a good time to catch you. So yeah, how did you get into breathing, by the way?
Well, it was very, very bizarre. If you want the complete honest answer, we have an appraisal once a year as part of an NHS doctor, and you've got to choose something to learn about that you don't know so much about. And normally I plan it. I'm quite organised, and that particular year I hadn't, and I knew all the things I didn't want to talk about. And it just came out. I said mindfulness. I don't know anything about it. I've had it. I think it's meant to be good. Tried to suggest it to patients, and they could see right through me that I didn't know anything or didn't know enough to make it sound attractive to them. So the lady, my appraiser, said, fine, that's great, go on that journey. And then I've had this most bizarre journey where, the next week I got an email to say there's a mindfulness for GPs course. I went on that. They suggest read this book. Read that book. It had a CD in it about meditation, and I've just gone on this really sort of unplanned, unstructured journey. And I think that the thing that really struck me was the neuroscience of it, how we can change our body. And I think at that point I was really quite disillusioned that the patients that I was trying to help had traditional medicine runs out of options for. We have a lot of complex patients with multi morbidity, lots of diseases, lots of medication. And I sort of felt the reason why I became a doctor was to help people, and didn't really feel I was sort of helping people anymore. And then ended up doing a lot of learning about neuroscience, then decided to do a therapeutic life coaching course. And it was in that she talked about the autonomic nervous system and linked breathing to that. Then did a bit of experimentation on myself, and then had a profound moment with a patient in a coil fitting that just was like, I've got to train to be a breathing practitioner, because there is something that is so important about this.
And we would love to see the science meeting breathing. I think it's got an enormous potential. Sometimes breathing is seen a little bit too over here.
Yeah.
And it can be tremendous. I know the science can be a little bit limited, the research can be limited, but we do the best that we can do, bring the physiology to breathing. Mm-hmm. And in this instance, you're working with different patients, and you spoke about working with people with chronic pain. Culminated with that is going to be chronic fatigue syndrome, obstructive sleep apnea. But returning back to the females, so how did you hone in on this?
Well, I was really, really lucky at the beginning of my career. You could apply at that point to do an extra 6 months of training with a bit of an interest. So I applied, was successful, and chose women's health. So at that point, I was trained to fit coils and implants for contraception. You can use it as part of HRT as well, one of the coils. And naturally, that was sort of like over 20 years ago. Naturally, then I've followed women throughout my career because I'm running clinics, doing these things. And naturally, I've got to keep up to date with contraception and HRT. And the things that I've learned about women over that 20 years is we're all different. The way we respond to different parts of our reproductive life is different. I have some people who don't even notice they go through the menopause, and some people have a terrible time. Actually, our bodies change. So what suited us maybe when we were younger and what suits us now completely changed. So it is, we are a diverse bunch. And certainly I really felt there was like a missing piece with menopause, that I try to help people with HRT and looking at other lifestyle things, but they definitely felt there was a missing piece. And then with the breathing work and what I learned from you, started to look at this steep rise in sleep disordered breathing as people go through the perimenopause and menopause. And then actually asking women, you know, how are you sleeping? Which I probably would have asked anyway, but then I asked the next question, how do you breathe at night? And obviously sometimes they're like, I sometimes signpost it, I'm going to ask you, it seems a bit unusual, you know, and like, is your mouth open? Have you started snoring? Does your partner, if you've got a sleeping partner, do they ever have to nudge you because you've stopped breathing? And I've been absolutely amazed at how many women don't breathe well at night. So many, it's untrue. Now, obviously, I see a skewed view. I'm seeing women who are obviously struggling for some reason. I appreciate there's lots of women who are looking at who perhaps are doing okay. And so I definitely, you know, the more people that I see are going to have higher risk of it. I get that. But it's, you know, and then the work that I do as a breathing practitioner, actually helping someone to stop snoring, or I've had individuals that haven't been diagnosed with sleep apnea, but their partner's been saying they've been having gaps in breathing, and then they re-educate their body and then their gaps stop and they sleep really well. So this is not fixed, and certainly what I think the NHS can offer is limited, definitely limited. And I think it's trying to get that message out there. You know, I sort of promote this sort of like 3A's approach. So aware, assess and action. So first of all, you know, I want women to be aware that how we breathe matters. And in particular, how we breathe when we're asleep absolutely matters for health and well-being. And then obviously trying to sort of suggest how they can sort of assess themselves to work out if they've got efficient breathing or not. And then obviously if they're ready and willing to give it a go, then they can give themselves the action part and actually try and change things.
So perimenopause, it can affect different females. It can come in quite early.
Yeah.
Will you just go through a little bit of, say, the transition into perimenopause? Does a female, are they vulnerable to different symptoms? Menopause, just to break it down for, say, somebody who may have no information, what is menopause?
Yeah, so I mean, essentially it's when we go from our reproductive life, when our body is essentially primed to potentially have children, and some women may choose to have children or not, or they may want to have children and not able to, but our body goes from being able to reproduce and potentially become pregnant, and then to a part of our life when we're not. The actual definition of the menopause is when you've gone a year since your last natural period, and then it's sort of like the post-menopause phase of your life. And the period of time where things start to change is the perimenopause. So that's when our hormones start to fluctuate, change, and we get this decline, this reduction in the amount of female hormones that we have. And that can be very short, but in a lot of women, it can be a number of years. And the difficulty in the perimenopause is we have huge swings of hormones. So it's not just a steady decline. You know, someday you can have a really high estrogen level and then it can crash. And women that can be really destabilizing for an individual. And one common thing that I don't think women realise is hormones affect how we breathe. So again, there's not enough research in it, and I hope at some point there's going to be more. But we've got, you know, testosterone, progesterone, estrogen receptors in our lungs, in our brain, particularly in the parts of the brain that control breathing. So it's really important, and how those hormones change and how it affects breathing does actually matter. And one thing that I think some women don't realise is the hormone progesterone. So that's one of our female hormones. If it's a synthetic hormone, we call it progestogen. But actually that stimulates, that makes us breathe faster. and also it's thought to have some aspect of increasing the strength of the throat at the back. And then as we sort of transition through and lose that, then potentially that airway is more likely to collapse, which obviously impacts sleep disordered breathing.
And this is
complex.
Sorry to cut across you. This is kind of different implications. So if you have a female going through monthly cycle, and at different phases, there's going to be an increase in progesterone, which is going to stimulate her breathing, which can bring on symptoms that can be contributed to or made worse by her breathing pattern during that time. And then the remarkable thing, as you spoke about, is that progesterone seems to protect females against obstructive sleep apnea.
Yeah.
So when progesterone production levels off, then the female, of course, is more vulnerable to the upper airway collapsing during sleep. Yeah. And of course, this could be made worse by body fat distribution as well. We're putting fat on the both male and females, fat in the belly. We've got increased fat deposits in the throat. We've got increased fat deposits in the tongue. It's really interesting, that whole transition. Menopause seems to be coming on the radar. Like, I probably wouldn't have given the word any consideration up until about 2 years ago, and now it seems to be falling all over the place. We're hearing it over and over. So do you think there's a greater awareness, coming back to those 3 A's, but there is a lack of awareness of the connection between breathing and dysregulation of the autonomic nervous system and menopause? You think something is happening now? People are starting to take note.
Definitely. So, I mean, I've been on a roller coaster with HRT, because when I first started, obviously, I developed this interest in women's health, and I was really upskilling my knowledge on HRT. Did a project on it as part of my training, and then a study came out, and the study that changed everything, that made everyone not want to have HRT, came out literally as I was qualifying as a GP, and that completely changed the radar. Now that study, there was lots of technical problems with it. So actually, I won't go into it, but yeah. So essentially, I was prescribing lots of HRT. Then in the middle of my career, done hardly any prescribing of HRT, and that data has been looked at again. And obviously highlighted the limitations of that study. And also now we've got hormones that are much more, we now understand how to prescribe it differently. So it's much more natural for the body, and we can prescribe in a way that doesn't increase the risk of heart attack and stroke, really minimises breast cancer risk. So I'm now prescribing lots more HRT to help women. I do also think, now this is my personal opinion, this is not, I'm going to give you a paper on it. My personal opinion, and I've observed people over 20 years, in particular women, is, and I've heard you talk about this, the amount of stress that people has got is just going up and up and up. And I do think that mask wearing over COVID, now I know I wasn't so au fait with the difference between nasal and mouth breathing perhaps pre-COVID, but I definitely think we've got so many more mouth breathers now because we've spent a lot of time in masks, coupled with just increasing stress levels, just generally living in modern day society.
Yeah,
and I think that is making the menopause transition more difficult, and that's my personal opinion. But
so there's a stress implication. If a female is more stress pre going into it, then she may feel different effects. Just coming back to the mask thing, I thought that was interesting. I wrote about, but I was getting my hair cut in Limerick, which is a city south of here, and the barber had a mask on. We were all wearing masks, of course, and the guy was only in his 20s, and I was listening to him breathe, and he was mouth breathing, but he was hyperventilating, and of course he's wearing a mask. He's feeling air hunger due to the pooling of carbon dioxide, and he's naturally responding with faster and harder breathing without realizing that the air hunger is actually okay if you transition to nose breathing, to slow breathing. So there would have been a lot of vulnerable people when they wore the mask, that the mask would have triggered air hunger. Yeah. And without them having the knowledge, they would have automatically went into faster and harder breathing, which is going to contribute to a fight or flight response. And then you combine that with the social isolation and the fear of it, the fear of walking down to the shop and not knowing if you're going to pick up something. So I would agree. And then you throw in internet, mobile phone technology. Doesn't that matter either, That's why live out in nature and get away from the whole lot. It could be very, very important and pretty much accessible to most people. If you have a car, you can get out 10 miles outside of your city, get out into a wood or something like that. So coming back to this, Louise, when you're working with people then with postmenopause, do you notice a pattern? And I know it can't be 100%, but do you notice breathing patterns? That how does that person breathe? If you were to compare their breathing to your breathing and you're just kind of observing their breath, is there any pattern there?
Definitely the more, well, what I found is the women that struggle more with transitioning through have definitely a higher chance of not breathing efficiently. So tend to be more open mouth, breathing fast, upper chest, breathing, maybe some breath holding sort of on the inhale, that type of thing. And then when you ask about how they breathe at night, that would be a common thing. I do think, it's challenging for a woman's body, particularly. I think as well, I think why women perhaps find it more difficult now than perhaps in the past is there's a lot more demands on women, perhaps working, parents, people are living longer, so might have elderly parents to look after. They may have had children later, so they've now perhaps got teenage children as they're in this transition period in their life. So all these things just add up on that stress. And I think there's definitely, there's this concept with women that you just got to keep pushing through. If something's difficult, just keep pushing, and not actually like, hang on a minute here. Let's just take a moment and actually look at the bigger picture. And I've come to the conclusion, and again, this is my own way I talk to people, is like, I think it's perfectly possible to thrive through the perimenopause and menopause. I think it is. It's difficult, but I think you need to step back and you need to see this this time of your life as it's a jigsaw puzzle, and there's lots of different pieces in that jigsaw puzzle. Like I'll mention some now, but there's loads. So what we drink, managing stress, sleep, breathing, being creative, having fun, sense of purpose, connection with others, resistance training, spirituality, sexuality, calm activities, lots and lots of different pieces. And sometimes if you look at it, all of it, it seems overwhelming. So what I sort of say is, well, be honest with yourself, try and pick a couple of pieces that you think you've got the most to gain from. Because some women literally can feel like they've just had the plug taken from them, and it's like they've got nothing left to give.
This is when they go through it, is it again? So when they're going through it, they feel that the plug is pulled. What symptoms might a person experience?
There's so many different symptoms. So I'm quite happy to say I went through my perimenopause, and it wasn't until I got my fourth symptom whilst I was running and thought, oh no, this is the perimenopause, so I missed it. And it can really creep up on you. And there's some, obviously, a lot of people will know, having your hot sweats, you had your night sweats at night. So a lot of people know that. I think there's more recognition now that you've got mood changes, anxiety can be worse. The obviously genital symptoms, there can be a lot of dryness in the vagina, which makes intimacy difficult. But there's other things. So I got hoarse voice, I got dry skin and joint pain. I mean, joint pain's fairly, a lot of people know that. But the hoarse voice, I just thought I was talking a lot at work. And the dry skin, this takes us back to what I'm saying, is that women, certainly I was just completely pushing forward, not paying any attention to my body, that, well, I've got dry skin now, and no matter how much moisturizer I put on, it's not helping. I've got hoarse voice, I'm having to go off and check that I've not got throat cancer. My GP had to refer, and luckily I didn't. And then I'm now like walking like an old woman when I'm trying to run. And I started snoring. So I started to snore.
Sorry,
yeah. So I started to snore, and then when I was I think it was when I was, so I think I must have snored, dry mouth, dry skin, so I got the hoarse voice, dry skin, and snoring. And I didn't really think perimenopause. And then when I was running, I was getting joint pain. That was when the penny dropped. And I went, for me, hormones was a big part of my jigsaw. I went on HRT and instantly my voice was normal. My dry skin just instantly went, and my joint pain went, and I could run normally. But my snoring did not stop. I was still snoring, and that didn't. And I know how I felt when I was snoring. You know, I couldn't concentrate, so, you know, brain fog. I was trying to be professional at work and struggling with my memory. Obviously, I'm then going to be more irritable because I've not slept well. My husband, who's next to me, he's going to be more irritable because I've disturbed his sleep. And then you might end up in separate bedrooms, and so all that. Mm-hmm. So I know exactly how it feels. And then when I was already on this breathing journey, and then thought, right, well, let's invest some time in improving my breathing. And then literally, I don't snore. I sleep the best I've ever have done. Have clarity of thought, and then this ability to self-manage my autonomic nervous system, to self-manage my stress levels, has been amazing. And then obviously now I run completely with nasal breathing, so it's which is just so much more relaxing, and I can recover much easier. So hence why I'm very, very passionate for trying to, because when you've been there yourself, and you can, I'm quite happy to tell that to people, and I know what it feels like. And you can, I might not everyone can stop snoring, because it depends on the size of the nasal cavity, doesn't it? But you can certainly make it a lot better. So I think it's really important that women know about breathing. But for me, definitely sleep disordered breathing, and how you breathe when you're asleep really is your unconscious breathing pattern, isn't it? So if you don't breathe well at night, you clearly are not breathing well in the day.
Yeah, it's amazing with obstructive sleep apnea with females. I think it increases 200 to 300%. I think sometimes the problem with sleep apnea that the studies vary so much. And you read one study and it gives you statistics of male females, and then you read another study and it's way off the charts. The one that stays in my head is 10% of females under 50 years of age, and post-menopause, depending, it's very difficult to categorize the age. It can happen typically between 50 and 55, is it?
No, I think you're right. But I've looked exactly like you. I'm confused now, because you look at so many different studies and they widely vary. But it's huge amounts of women that it affects. Yeah. And you could say, well, that's in a paper, but I'm asking the people that I work with, obviously the people that see me privately already they're coming to me because they know that they want to improve their breathing. But obviously I see a huge spectrum of people at the surgery, but the amount of people there that have sleep disordered breathing, male and females,
it's really common.
It's massive, massive.
Yeah, massive. There's a study in The Lancet, was published about 5 years ago, 1 billion people worldwide. So out of 7.3, so 1 billion. It's absolutely phenomenal, and it's increasing. And it's increasing due to a number of things. And I think stress does play a role. Like, I've often wondered why people with PTSD are more prone to obstructive sleep apnea. What's that connection there? Because you would think that obstructive sleep apnea, primarily was an anatomical problem, but there's obviously other factors that are coming into play. So coming back to the females then, post-menopause, their susceptibility to obstructive sleep apnea, it can increase 200 to 300% to about 30% of that group. You were talking about breathing exercise, and I think it's really important to qualify what breathing exercise you were doing, because breathing exercise are a bit like physical exercise. You can go for a walk, you can do a sprint, you can do weights, you can do any sort of. So specifically, what did you feel was good, and what was the purpose? You were talking about the autonomic nervous system. So your goal was to help to bring balance. And I'm sure you did other things than breathing, but breathing was one of them. And what breathing exercise did you do?
Well, I think the big I've had a couple of aha moments in my career. So definitely that aha moment of, oh, you're meant to actually breathe through your nose all the time. Like, otherwise, if you breathe through your mouth, you're just dragging in dirt, muck, virus, bacteria, and then cold, dry air that actually triggers the cough reflex and spasm of the breathing tube, so wheeze in an asthmatic. That was an aha moment for me. So I think that was definitely an aha moment, and I think it's realizing. The other moment is breathing is, we do it automatically generally, but it doesn't mean it's automatically efficient. And that definitely, I wasn't aware of that as a medic. Everything that I learned with you and I've learned subsequently, to be honest, I have been taught it generally, but it's that practical application, you know. So I was taught all the functions of the nose, but I just needed to be told one thing. So use it to blooming breathe, you know.
We'd love to see it we'd love to see breathing coming into medical college, you know. I think even just for doctors to be able to self-regulate. It's like a highly stressful job, regardless, irrespective of training. And so I'm assuming that some of the breathing exercise that you were practicing to self-regulate just involves simply slowing down everything.
Yeah.
Taking that soft breath in through the nose and a really gentle, relaxed and slow breath out. And even just softening the breath, ideally, of course, with a feeling of relaxation, but okay. But just gently softening the breath to the point that you get that tolerable air hunger and sustaining it then for a period of time, maybe starting off with 1 minute, 2 minutes, 3 minutes, 4 minutes. That's my favorite breathing exercise, by the way. Nobody knows you're even doing it. And I think that's one of the powers of it. But you'd often feel that that's really what the body, if the body is going through a transition that's stressful, we need to be able to help counter that. So, and if poor breathing is part of that, we want to be doing the opposite. Did you practice it? Did you bring it into it? Because you were fit anyway. That's another thing. You were fit, you were healthy going into this journey. And yet you still had the symptoms.
Well, exactly. And that when I first thought, well, there's nothing wrong with my breathing. Like, why would I have to like re-educate myself to breathe well? There's nothing wrong with my breathing. I run 3 times a week. I've got a healthy weight. But then I read the definition of sleep disordered breathing, which obviously is if you snore. So I clearly have sleep disordered breathing. So there is an issue with my breathing. And you know, why have I got an issue with my breathing? Well, I'm going through the perimenopause. I talk a lot for my living, so that definitely makes. And I've got a job that's really stressful, and I'm going through the perimenopause. So I've got factors there that influence it. And I think one important thing women should be able to think about is we've all got different efficiencies of breathing. So you know, my breathing wasn't good, but I've certainly seen individuals where it's a lot really, really inefficient. So so there's a scale of inefficient, you know, you can have efficient breathing, really very inefficient breathing, or you can be in between. And I have some patients at the surgery that, you know, a common one would be, I've got a cough, you know, I can't get rid of the cough. I do all the traditional medical stuff, you know, checking for various things. Generally it involves sending them off for a chest x-ray. So I'll say to them, what, you know, you're going to wait for your chest x-ray now. Can you just observe your breathing over the next week or two? Are you breathing through your nose when you're awake, asleep and moving? And if you're not, could you just give it a go of trying to breathe through the nose? And a brief explanation about air hunger. And, you know, if they feel air hunger, it's not their oxygen dropping. And it's amazing how many then, and I generally then cite, if they sort of look like, I may be more of a mouth breather, or I'm doing a lot of mouth breathing, I'll give them a podcast. So the one you did with Dr. Chatterjee or James Nestor, those 2 podcasts I have on a Word document. I can just literally just text them the link and say, you know, just observe your breathing. If you're noticing you're doing some mouth breathing, could you have a listen to this podcast? So it's, you know, is it relevant for them? If it is relevant for them, listen to this podcast. And did you know that if you mouth breathe, you'll breathe cold, dry air in, and it will give you a cough? So let's, you know, out of interest, while we're doing this traditional medical thing, let's see. And the amount that come back, like, my cough's gone, or it's like 99% gone or something. And then you're, you know, then I can, in my NHS work, I can't do like full-on breathing re-education. So it's a lot of signposting. A lot of your books get signposted. So, you know, depending on what their symptom is, I'll suggest one of your books to practice the exercises. And I've developed on my web page, again, partly because of the patients, I can't do really in-depth work with them, but I've broken it down because I think what they need to understand, it's obviously about making sure they're not over breathing, so doing breathing exercises to train their body to not over breathe. And if it's an NHS patient, I'll say one of your books, so like sleep, if they've got snoring, it's they sleep with Buteyko. If they've got asthma or nasal congestion, it'll be close your mouth. If it's more a stress thing, it'll be atomic focus. So I'll say you can teach yourself those exercises in that book. And then I've got the other bit where I'm talking about the tongue position, nasal breathing. I quite like the Vic Veer throat exercise video. So he's an ENT consultant, and he's got some exercises that he's picked out that he says he's found some evidence for in papers. And I say, why don't you practice some throat exercises every day? And I put a bit of the science on the page as well. So
what's your web page, by the way?
So I'll it's very, very long. So I can message it to you. But if people Google Dr. Louise Oliver Menopause, they'll get my website. And but I'll give it to you. It's probably easy to put in the.
We'll put it into the footnotes.
Yeah, because it's got podcast information at the end, and it's a really long web address. But I've just tried to make it so my colleagues can share it, and just so if a patient's interested, there's a lot of information on it, but it's trying to set out that it's about the breathing volume, but it's also about making sure that airway's open, and obviously getting the mouth closed at night as well, because I can't spend a really long time with the NHS patients. And those that are motivated, they have improved, but obviously those that are very inefficient at breathing, it is very difficult to do it on their own, because they need to be handheld. Quite uncomfortable initially.
Yeah. And you know what? Even with the more vulnerable people, and they were people that, say, somebody coming in with chronic fatigue syndrome and needing to realize that their autonomic nervous system is very taxed. And I've made mistakes in the past. I gave exercise that were a little bit too strong for the people. I completely floored them. And we really have to dial it back. And I think even just giving the person instruction, do your best to maintain nose breathing during rest, especially when you go for a walk, during sleep. If you're feeling stressed, really focus on slowing down the speed of the exhalation, having the tongue resting up the roof of the mouth. And maybe just in your living room in the evening, you might be having some downtime. Just put one hand on your chest, one hand just above your navel, and start practicing slowing down your body. Because when we have that soft breath in, the really relaxed, slower, gentle breath out, the body is telling the brain that everything is okay. And I think people get it, because they realize whenever we get stressed, our breathing is a bit all over the place. When we start breathing faster and harder, and we're irregular breathing, our mind is all over the place. So there's a connection between the breath and the mind, and vice versa. You are limited, really, isn't it? In terms of a GP working with patients, you've got 15 minutes, and it's difficult to give that in-depth exploration. But at the same time, 15 minutes, you can impart some information that can be very helpful for people. Yeah. Do you see people coming back with reduced symptoms, say the menopause, hot flashes, for example?
Yeah, definitely. I mean, the one part that there's all sorts of patients that there's all sorts of well, I suppose this is with my private. I'm trying to separate my NHS work and my private clients. I mean, I've had also, and it's difficult because they all get mixed into one. But it is amazing how many different symptoms improve when you improve your breathing. I tend to promote, I can quite confidently say, you'll be able to, you'll be less breathless with exercise. You'll sleep better if, obviously they don't breathe well when they're asleep, and you'll have an improved ability to self-regulate, stress and stress resilience. So I generally come from there. But there are lots of symptoms. So I've had people who their eustachian tube, when they get a lot of they have problems with like ear pain and things. So I've had people with that. I've had someone on my current course, her volume of her tinnitus has massively gone down. One of the patients, this is the patient from the surgery. So again, she mentioned she was snoring, and I did my usual thing of mentioning the importance of the nose. And I sometimes put an oxygen saturation probe on their finger, because some people, even just shutting their mouth, they get air hunger. and it can be really powerful. You can just put it on and just say, right, just close your mouth. I just want to just see if you can breathe out your nose for a minute. Let's just see. And you can sort of see if they're getting in their eyes, can't you? If they're getting like air hunger, you say, look, it's fine. The oxygen levels are absolutely fine. This is the carbon dioxide here. It's gone up. You can retrain this. And I quite like telling them, I don't know if you know this, but Kate Winslet, in her last film, Avatar, she's the same age as me. She was offered, there was a free diving sequence in it, and was obviously offered a stunt double. And she said, no, thank you, train me to free dive. So obviously she was trained by a professional. Clearly, you can't do that without being trained properly, otherwise you risk death. But she did a 7-minute breath hold and beat Tom Cruise, apparently. So that story goes down quite nicely, because I say, you know, she's the same age, you know, she's a in her late 40s, who, you know, has trained her body. Obviously, it was part of her occupation, but you can train your body to be less sensitive to the buildup of carbon dioxide, and the benefits from that are huge. You don't have to go down the free diving route, obviously, say to them, but if they don't want to, but it's just but that's something that's quite easy. You know, you put the SATS probe and I find that really powerful, because they notice then, well, my oxygen level didn't drop, but I'm feeling like I'm suffocated. Then they know they get the carbon dioxide in a real practical way. So that's been really helpful.
I think it's really important to do that, because I think, especially if we have somebody, say, coming in that's vulnerable to panic or anxiety, oftentimes air hunger, well, they will call it suffocation, and they are terrified of it. And the air hunger is driven by an accumulation of carbon dioxide. But just for some of us, we're overly sensitive to the accumulation of the gas. And that's why it's very important to do gentle breathing exercises that over time that you can desensitize your reaction to it. Because I often feel it's the suffocation that's driving back into the stress response, that's feeding into the suffocation. There's a vicious circle. There's a vicious circle there. So imparting that advice in terms of, for people to feel comfortable that, a little bit of air hunger. I wonder, we had a question there come up yesterday as well. I probably won't go down a rabbit hole. We'll stay on topic. But sorry, Louise, I kicked in there. So your patients overall, you find that well, not everybody is going to be approachable about breathing, but I think breathing has got a tremendous space in terms of getting it out to the very everyday person with the language that we use and bringing it down to their level, because it is very accessible. You know, it's tremendously, like, even go for a walk with your mouth closed, you are doing a breathing exercise per se. Where do you see it going?
Well, I think health professionals, they need to know about it. You know, this is not, there is nothing weird about Buteco or breathing through your nose or training people to breathe well. There's nothing weird about it. We have been designed, you know, to breathe through the nose. That's how we've been designed to breathe. It's just that we're not doing it. And the science is there, you know, it's just getting that across, the practical application of it. So I think health professionals need to be aware of the importance of breathing through the nose and encouraging people to breathe light and breathe low and slow, definitely. I think we know this, but I'll just say, to breathe well, you need those three things, don't you? You need the biochemistry, breathe light. So you need to not be sensitive to the buildup of carbon dioxide. You need to breathe low with the diaphragm, using the correct muscles, and breathe slow, which is all to do with the sort of physiology and the psychology of it. But the trouble is, it's much easier, and I fell in this hole before I sort of started my breathing training, is it's so much easier to tell a patient, oh, I want you to breathe at 6 breaths per minute using your diaphragm. So I did that. Yeah, so I'm only focusing on biomechanics and the slow breathing. And so I'm saying, and then some of them, it worked really well. And some of them, I made them feel awful. And it wasn't until then I realized that it's because we have this spectrum of breathing inefficiency. And those that are really sensitive to the buildup of carbon dioxide cannot tolerate breathing at 6 breaths per minute. And the only way they can do that is to overbreathe, mouth open, massive breath in and out, and you essentially make them hyperventilate and make them worse. And I because I spend time fitting the coils with women, I'm with them for a long time, and it's an attractive prospect to use breathing to try and help their pain. So obviously I experimented with some of this, and some women, I had a very profound moment, which I made her into a very relaxed state, which she has given me permission to talk about it anonymously if you want me to go into that. But I changed her very profoundly, and it was that moment that I thought, right, I want to train as a breathing practitioner. But then I've done that with other patients, and I've made them feel terrible. And that missing link is definitely about carbon dioxide sensitivity. But that is the bit that is the most difficult one to teach, and it is more difficult. Obviously, if someone isn't too inefficient, exactly what you said, just go for your walk, make sure it's nasal breathing when you sit down, exactly. But I've got individuals that are coming out of long COVID clinics that have control pause of 3.5 seconds, being discharged, saying there's nothing we can do for you. We've done everything. That's it. You'll just have to pace yourself and just get on with it. And these people are there's one aspect of their breathing that is not being addressed. And that may not be, this is my experience of the clinics near me. I fully admit around the world and different parts of the UK that may be different. I know there are.
Well, I've seen as well on COVID before. I would, coming back to that breathing point, I would totally agree with you. Giving people instructions maybe to breathe in for 4 seconds and out for 6. Theoretically, it's a great instruction because it's the perfect respiratory rate to bring down the breathing rate down to, say, 6 breaths per minute, which helps to balance the autonomic nervous system. But if we think of the person who needs it most, the person who is breathing faster with a respiratory rate of maybe 18 breaths per minute, breathing up her chest, feeling air hunger. So here's the person in their everyday breathing. This is how they breathe, not just during a stressful situation. And then we asked them, if we were to ask them to go from 18 down to 6, the transition is just too much. And they will just amplify the tidal volume. So even though they are reducing the respiratory rate, the volume of air that they breathe in during that breath is going to be increasing disproportionately. So they end up over breathing, which is going to feed into their symptoms. It's a great point. And I think that's the importance of being able to tailor breathing exercise then according to the person that you're working with.
Yeah, definitely. And it is, I think, teaching carbon dioxide, teaching individuals to be less sensitive to the buildup of carbon dioxide has been profound for me, because I now, I can help people feel, or at least help their basic foundation of life breathing to be better, to not feel this horrible air hunger. And the people just breathe then naturally, even if you don't do any work on diaphragm and breathing slow, they naturally, you're asking them to nasal breathe, become less sensitive to the buildup of carbon dioxide. They breathe slower anyway and lower. And then your natural, I remember the moment when I corrected my breathing, and like we described, that you get this point where there's a short pause after the exhale before you breathe in again. And I remember being at rest and thinking, oh, I've got that. I don't feel this drive to breathe in. And then when you're at rest and I'm on the computer on my own or chopping veg, you're breathing like that. Your just natural breathing pattern is really soothing, completely soothing. And then you're less reactive then to, I would love to do a study, and this is my personal thing. I would love to do a study on someone's brain before they do breathing re-education and afterwards. And I would love to know what happens to the size of the amygdala. So that's that part of that brain that has part of a role of fear. Because I know from reading a book about meditation, you do meditation and it makes it smaller. So if I train my breathing to be really slow, gentle, and it's constantly stimulating that parasympathetic, and I'm feeling calmer all the time, surely my amygdala's got smaller. And I definitely, I've been known for my fiery sort of personality. I'm probably more of an extrovert, but I'm definitely calmer. I'm definitely less reactive, and it's a physiological thing. Definitely. And I would love to know what the size of my amygdala was before I started this and afterwards. So if there's anyone listening who's going to fund a study, I think that would be...
It's like, we'd love to see more studies on breathing, but specifically the breathing exercise that we work with, that we're seeing the results with. Michael Binder's paper, the neuronal hyperexcitability hypothesis. So he's a psychiatrist in one of the universities in the United States. He said the psychiatric population, if you were to add up those with severely elevated hyperexcitability of their brain cells and severely, it was almost 3/4. Whereas in the normal general population, if you were adding that cohort, I think it was only about, it wasn't even a quarter, maybe about 15% or so. And then we look at the connection between what happens if we are breathing harder and faster, and we're breathing a little bit too much air, and that's blowing off too much carbon dioxide. That in turn will increase neuronal excitability. And then we know that 75%, even though it's understudied, 75% in the studied population of anxiety and panic disorder have dysfunctional breathing. And then we have to ask is their everyday breathing then feeding into increased neuronal excitability? So the brain cells are firing all over the place. They are all over the place. This is an interest, because I often feel with mindfulness, can you imagine if our minds are all over the place and then somebody says start paying attention to present moment awareness? You're going to say, listen, it's not possible. But you could do breathing exercises maybe to help self-regulate, that even some of them don't even require paying attention to the breath. And I think it's more direct. You can target it very specifically. If the elevated breathing pattern is feeding into symptoms, well, why not target specifically the elevated breathing pattern, but also take into consideration, as what you said earlier on, that tidal volume.
And just on one point about mental health, I've had 2 patients recently that both have quite severe mental health, one male, one female, but their nightmares, both of them have lots of nightmares. I tried to explore about sleep apnea with them. No, I don't have gaps in breathing, but they do heavily snore. And luckily in the area that I am in, I can just refer on a suspicion. I've not had a referral sent back to me, and I've just said I'm concerned. Can we just check these people don't have sleep apnea? And both of them have very severe. Really. And one of them had an AHI index of 94. I didn't realise it was possible to have.
I didn't even know it was. I've never heard of one as high as that. Wow.
94. And to me, obviously, it's on my radar. But it was. I had to tease out that they were snoring, and they definitely didn't think that it had sleep apnea. But I just said, well, can I just do the referral, because you've got nightmares and you've got snoring, and sometimes this is associated with sleep apnea, and both of them have got very severe sleep apnea. And I think the other thing, I think in one of those menopause studies, was a lot of women tend to not come to the doctor saying they're snoring or got gaps in breathing. They're more likely to say insomnia, anxiety, fatigue, nightmares, those types of symptom. And I think it's trying to raise awareness with health professionals that it's other symptoms that present, and you need to, obviously, you still just consider it in your differential diagnosis that it might be something that they're suffering with. But for me, the most important for me about getting health professionals to understand this is to experience it themselves, or to see somebody they know improve. So on my virtual groups, it's been really good that I've had some doctors on my courses that I'm not breaking confidentiality because I've put it on social media, but they've seen individuals on the course improve. And there were people that they knew, and that was really powerful to them. Doctors that I work with, again, I've got a doctor that snores, and again, he's just doing a little bit of work on trying to do more nasal breathing, and I think he did a bit of box breathing, but his snoring's gone down. And then once you experience that, you realize, and okay, yeah, there's more to this. So it's trying to get, I think that's a powerful way of doing it, really.
I would totally agree. Irrespective of the science, is actually getting people, do they feel any different? I remember I was giving a talk to 150 ear, nose and throat doctors in Madrid back in 2019. and they were split into two. The room wasn't able to fill, but didn't have that capacity. So 75 come in on one day and 75 come in the other day. And okay, here I am fretting ENTs. I better start really go down the whole science route. So that's what I did on day one. And it's limited. You know, the science is not so black and white either. There's some gray areas there. And then on the second day, I did a combination of physical exercises, doing the nose and blocking and the science. And then the feedback come back. And the feedback was so much better on the second day. But I remember the ear, nose and throat doctors, I had them breathe in, breathe out, hold their nose and do the nose and blocking exercise. And I was looking out into the audience, and some of them started looking at each other after the exercise, knowing that, wow, I feel some difference to my nose. And these are ear, nose and throat doctors, you know, that kind of way. So I thought that was cool. Yeah, it's the experience is really, really key, because I just feel that breathing has been let down for so many decades. And you know, I think we need again to bring it. It's really right down the center. You know, there's nothing left of field about it. This isn't alternative. This is a perfect complementary adjunct that can be used from people with respiratory and mental health issues and sleep. And I really like that you were working with people who were having high anxiety and high panic, and you picked up on their sleep. Here's a question. Do you think that people with mental health issues will ever get to the root of their mental health issues? Now, it's going to be your personal opinion, if they have continued sleep disorder breathing, but that's not being addressed.
No. Yeah. Because absolutely not. And you know, probably one of my biggest passions with breathing is sleep disorder breathing, because you know, by definition, if you're not breathing well when you're asleep, that means your unconscious breathing pattern is not efficient. And you should, when you're asleep, your body should feel safe. Your body then should go into that parasympathetic, that relaxation response. And then actually sleep's a very active process. Your body then repairs and recovers your body, but it won't do that if it's still in that fight flight mode. And that's definitely what I bring in with people is, you know, you've got that autonomic nervous system that controls everything in your body, and it could be in fight flight or in this relaxation response. You know, if you're breathing at night, open mouth, loud, holding your breath, irregular, your body literally thinks it's being attacked. It's going to keep waking you up. And then you're not going to sleep well. And we know that to sleep well, you need this relaxation response, so the body can then do the active processes of repair and recover. And that's repair and recover physically. But we know there's certain stages of sleep where they do all the emotional processing. So you're not going to do that if you don't have the correct stages of sleep. You need all stages of sleep are important for different reasons. So sleep disorder breathing is so important. And medics, we make things so complicated, don't we? So, you know, you want to open the airway up. So let's put a mandibular advancement device on here and drag it forward to drag the tongue out of the airway. Well, can we not have the individual practice the tongue in the correct position? And certainly, you know, now I'm teaching people and I've got the experience, I can say, you know, you can train someone to put the tongue in the correct position and it stay there. It takes 3 months though. And I will tell people that and say, you're creating new muscles, new nerve connections. So this isn't going to be better after a week. You've got to do it. You know, every time you fill your water bottle up, you sit on the toilet, you wash your hands, you put the kettle on, you just need to go tongue, and it needs to be flat on the roof of your mouth, not in contact with your front teeth. Make sure your lips are sealed. Don't clench your teeth. Slow nasal breathing. Just do that. How many times a day? If you do tongue routine like that, you're constantly bringing yourself back to nasal breathing, correct tongue position. Yes, it might ache. You know, I think it's a positive thing. I'm definitely better under here, and I've got more definition here since I've practiced my tongue position. It will ache for a couple of weeks, but that's a good thing. That shows that you've not had the muscles there. And then people feed back to you, oh, I actually woke up this morning, my tongue was in the correct position. And then obviously they carry on, and after 3 months it's a more natural thing. But you know, so, and I know there's some people that obviously there's different spectrums, but they're even fitting this nerve stimulator now to the bottom of the tongue, aren't they, to fire a signal to push the tongue out of the airway. But can we not, you know, can we as medics just tell people there's a correct way to put the tongue, there's actually a correct swallow? You know, there's lots of stuff on the internet. You know, they can. I know we're not qualified in it, and I know obviously my functional therapy, we currently in the UK, I don't have access to that. But patients can do a lot of reading themselves and teach themselves.
Louise, I totally agree with you. I really feel with the sleep industry, and if you look at the CPAP, it works, which is continuous positive airway pressure. And the idea came from, for those listeners who don't know about it, it's a vacuum cleaner in reverse, to put it crudely. So it's basically a device or a unit that's pumping air into your airway at a sufficient pressure to splint open the airway. Now, on the basis that continuous positive pressure air opens up the airway, how about looking at reducing the negative pressure created during inspiration from an anatomical point of view? And basically, that means, can we change breathing patterns that they are lighter and slower so that there's less negative pressure? You also spoke about the anatomy in terms of the tongue resting up in the roof of the mouth, breathing in through the nose, which is going to help open up the airway. And a good airway is just this side. We don't have much room for air. So you can imagine when the mouth is open, or if you have jaws like mine that are set back, you know, the airway is already compromised. Sleep apnea has moved on. Luckily, since 2013, there was a paper by Danny Eckhart, and he talked about PAM. He talked about peak crit and arousal threshold. L is for loop gain, and M is for muscle recruitment. So those 4 phenotypes, and breathing can play a role there. And I would love to see today that there's 100 people selected with established obstructive sleep apnea.
Yeah.
And let's teach this group of 100 people myofunctional therapy and breathing re-education and see what result comes out of that. Because if we look at the current treatment, which is the first line of treatment is the CPAP machine, 50% of people abandon it after 1 month. And if you're mouth breathing while wearing the CPAP, your adherence to the CPAP actually reduces. There's a 2004, I know it's a little bit old, 2004 paper. They looked at 70, I think it's 70 people with obstructive sleep apnea. If you had the mouth open, only 30 of them continued with sleep apnea at 1 year follow-up, but 70% of those who were nasal breathing continued. So the compliance rates are much higher with nose breathing while wearing the CPAP versus mouth breathing. And then the mandibular advancement is the second line of treatment, but it's not always easy to predict who that's going to respond with because different phenotypes or different characteristics. And then they looked at using adhesive mouth tape. Now, surprisingly, some people got worse with the taping. And this was kind of news when I was looking at it and because we've been kind of encouraging taping as an integral part as a support for many, many years. And this was due to mouth puffing. And then I was up on my treadmill here one day and I was wondering, okay, what's this? How do you replicate mouth puffing? But if you push yourself during physical exercise to a point whereby you're feeling quite breathless with sustained nasal breathing, at some point, your drive to breathe is so strong that the air has to come out through the mouth. And that's what I was thinking, okay, mouth puffing then is happening, that the individual is breathing so hard and so fast, but there's so much negative pressure, a combination of their breathing, but also the anatomy, that they're blowing out through the mouth. And with the taping of the mouth then, that's why we were lucky as well, with just by chance, with the myotape, that it allows the mouth puffing in comparison. So what I would say is, if anybody is listening, if you do have severe obstructive sleep apnea, or if you're quite obese, never put the tape right across the lips, because it prevents mouth puffing, which could worsen your sleep apnea. But if you can have something that can help bring your lips together and being conscious of your breathing during the day. It's really interesting, isn't it, the whole sleep medicine? By the way, did that form much of your training when you were a GP? Sleep disorders?
No, definitely not. I mean, I don't remember being specifically talked about it. It is interesting. The one sleep study clinic letter I've seen recently actually did recommend the Vic Veer throat exercises. So I did think that was, oh, right. So we're actually thinking not just CPAP machine. It was only one letter. But my experience is if if the patients go to the clinic and they obviously get asked, are you a mouth breather at night or a nasal breather? And then there's no, again, we're making this more complicated, aren't we? Just, oh, right, you're a mouth breather, right, you have the full mask, rather than, oh, you're a mouth breather, could we convert you back to a nasal breather and then you can just have the nasal? You know,
yes,
to me,
yeah, even like, and when we look at the CPAP adherence, like for it to significantly improve with nose breathing, it's well documented in obstructive sleep apnea that mouth breathing worsens, or at least those individuals who are breathing through an open mouth during sleep with established obstructive sleep apnea, they worsen. It would make total sense.
Yeah.
Breathing has kind of been a little bit overlooked.
Oh, massively overlooked,
massively.
definitely.
Yeah. And that would be, I would love to see the day that it was one of those pillars, you know, just as doctors are becoming more involved with nutrition and physical exercise, and breathing should be alongside those three pillars as main pillars. And, you know, we think about breathing, we think about mental health, we think about sleep, we think about respiration. It can influence all of those things in the positive. Yeah. I'm just going to come to a close because I'm conscious of time. So I think it's tremendous and brilliant as a GP that you have discovered breathing and that you're working with it and that you're educating your clients. I think it's excellent. Where do you think we need to go with it? If you were to look 10 years into the future, and where do you think, or is it probably I'm putting you on the spot, but
I think every health professional needs to know about it. And being honest, I think I would probably encourage every health professional to read James Nestor's Breathe book. Really simple, or at least listen. I think the book's really good because I think it's coming at it from someone who, you know, me and you invested in. Gonna say it's important, but he's a scientific journalist who's come at it again, not a planned thing, I don't think, triggered by, I think I heard him say on a free diving piece he had to do. So I would actually encourage every health professional to read that. And I don't, and what's in that book is true. What's in that book is true. And that's the first basic thing. And then start to experiment with their body themselves and see what happens, and actually start observing your patients before you pull them in. You know, is their mouth open? Can you hear them breathing as they come in? What are they breathing like in front of you? And certainly the health professionals I've been working with, they now see it in their patients and they're asking them particularly how they're sleeping at night. So, and I think, being honest, I don't think who's going to fund a massive study on breathing? You know, it won't be a drug company with it, you know. So yeah, I would love, the first thing I'd like people to be coding on the computer dysfunctional breathing. I have asked for a code. I'm certainly not convinced it's been I can't get it on my computer. So that's one of the issues we've got, Patrick, is if I recognise dysfunctional breathing in a patient on my primary care system, I can't code it. So obviously then the NHS doesn't see that it's rising. So first of all, I need a code on the computer. I then need health professionals to code it when they think it's relevant. Then the NHS will see there's a steep rise in it. And then perhaps some money will get invested in it. But yes, but I would love obviously lots of research into it, and particularly the research, particularly with women. I think any research papers have to do three things. One, we have to recognise that women breathe differently at different points in their cycle and reproductive life. That alters things. There's different efficiencies of breathing. So depending on how efficient your breathing is will alter results. And the other thing is actually the time of day alters how you breathe, because you're less sensitive to the buildup of carbon dioxide later on in the day. So if you're doing studies and you don't take that into account, your results are going to be affected by that. So yeah,
I agree with all those points. We definitely need to see the changes in terms of how females breathe differently to men. It's been known since 2015. It's been known since 1915. And there was kind of a handful of studies here and then. So even though it's going back over 100 years, it was overlooked. And most research on breathing has been done on men. And even when it was done on women, they failed to take into consideration the monthly cycle. So it does need to get to that detail. So Dr. Louise Oliver, that was a pleasure. Thanks very much for this conversation. I think it's going to help people. I think it's great to get this information out there. So yeah, wonderful. Thanks very much.
Thank you. Thank you.